I looked at the website, and the Epilepsy Foundation does not favor strict time limits. It instead favors individualized approach to every patient, because no two people are different who have epilepsy. Some people have seizures only when they are asleep. So should they stop driving because they have seizures only at night or asleep? You know, if all the seizures occur during sleep, would you restrict the daytime driving? And so there are some issues which come up. Preventing treatment-related mortality. You monitor for and avoid life-threatening adverse effects. So this is the responsibility of the physician and to some degree of patients. But it's important for physicians and healthcare providers to monitor and to look for and to inform patients about potential life-threatening side effects. Now, hopefully, thankfully these are rare, but you can sometimes have irreversible side effects like a severe allergic reaction where there's peeling of skin called Stevens-Johnson syndrome, liver toxicity, which sometimes can be irreversible, bone marrow suppression or shutdown of the bone marrow, or pancreatitis. So these are some of the severe side effects which are seen with seizure medication, which can potentially cause mortality. Depression is another cause. We know that most patients who have attempt suicide are depressed, and we know that the risk is in epilepsy is 5 times that of general population. The risk may be up to 25 times in temporal lobe epilepsy, and also increase in frontal lobe epilepsies. But the rates are similar to other neurological illness such as traumatic brain injury, neuromuscular diseases like ALS, and multiple sclerosis, which makes us think that the risk of depression seems more related to the person's impression of the illness or the impact on the quality of life rather than the inherent seizure causing the depression. So these are possible causes of depression in epilepsy. It may be due to the underlying cause, which it could be a brain tumor, could be stroke, and that can sometimes predispose a person to depression. It could be as a result of medication. We know that many medications have depression as the side effects. Medications like phenobarbital and primidone increase the risk of depression significantly. It can be quality of life issue. A person with epilepsy who is not able to drive, who is not able to go to work, who is not able to enjoy life with without fear and without apprehension, is more likely to have reactive sadness or depression, and it can be caused by the seizure. I had a teenage patient 2 weeks ago who one night was visiting her boyfriend and suddenly started to act very strange and started, for the first time ever, started talking about, I wish I was dead, I wish I was dead. Turned out that she had a seizure. She normally does not express that emotion, has never expressed that emotion at any time. And after about an hour, she was back to a fine, usual, happy self. She's never been depressed. So clearly, sometimes having a seizure, you can have Ictal depression related to the seizure itself.
She's verbalizing that. Would they'd be more prone to follow through? Break themselves when they're...
This patient was seen by psychiatry, and she was felt not to be a suicide just like 2 or 3 hours later. And she was admitted overnight, and they felt that it was related to a seizure. People can even have post-ictal psychosis. People get agitated, they hallucinate, they see things, and that can occur after a seizure. People who do not have psychiatric disease.
But they're not, they're not themselves. Would they be more apt to hurt themselves, or is it just psychosis?
Ictal psychosis, the likelihood that they would hurt themselves would be very, very small. But the depression related to other things like the medication or as a reaction to quality of life, I think the risk of suicide would be high. As I'll come later in the other later slide, there is, as I mentioned before, the risk for suicide is also increased. It's about just like depression is about 5 times that of general population, but if you look at patients who have temporal lobe epilepsy, epilepsy, because we know that the temporal lobe is attached to the limbic system, part of the limbic system, including the amygdala, the hippocampus, the entorhinal cortex, and it is if you look up limbic system and on Google and type in and look at the pictures, the picture part of Google search, you'll see nice pictures of the limbic system. It's like a circuit, a round circuit, which attaches different parts of the brain. And you know that patients with temporal lobe epilepsy are more prone to depression and to suicide, 25 times. And Barraclough, the study I quoted here, looked at 11 studies, and out of 10 studies, it found clearly increased risk. The average was 25%. So it's a significant risk for suicide. It may be higher in certain medications such as phenobarbital and primidone. I quoted one study, but there was another famous study from Pittsburgh many years ago by Brent, which looked at very high risk of depression in patients who are taking phenobarbital. Sometimes patients may experience suicidal ideation after a seizure, but luckily that's usually very brief and short-lasting. And so preventing risk for suicide is very important. The onus is on the physician and for the healthcare provider to look for those things, to look for sadness, for unhappiness, for poor quality of life, perception by the patient, and treating the underlying depressive illness. This is a very, depression in epilepsy is a very treatable condition. It's very treatable with medications, with counseling, with therapy, with cognitive behavior therapy, with family counseling, with manipulation of situation. And focusing on quality of life has become very important. All the new drugs from 1990 were required by FDA to include quality of life measures in the pre-marketing information, because the patients were required to fill this long questionnaires on quality of life. And even the vagus nerve stimulator, before it was allowed to go on the market and be approved, required quality of life measurements to see, did the medicine just treat the seizures, or did the medicine improve the quality of life? Did it reduce depressive symptoms? Did it make you feel better about yourself? Did it make you less prone to being sad and unhappy and anxious? And I'm not going to look at anxiety. That would be a different whole topic altogether. But so it's important to avoid medication which cause depressive adverse effects. Now, having said that all medicines cause depressive symptoms, some of the new medicines can also. But the newer ones are less prone to causing depressive symptoms, and certainly trying to achieve seizure freedom is a very important goal. I mean, it cannot be achieved in everyone, but trying to strive to that is very important.
So you could be on seizure medication, but also be on an antidepressant?
Yeah. Now there are certain seizure antidepressants which can lower the seizure threshold. So the neurologist or the psychiatrist has to pick one which have a lower seizure risk.